So I'll be talking on phaco in vitrectomized eyes. No financial disclosure. So when we are operating on a vitrectomized eyes, pre-operatively we have to sit down, we have to think what is different in this eye and what planning we have to do pre-operatively. I'll be covering that first. So we know that vitrectomized eyes need special considerations as they manifest altered behavior. What altered behavior we'll be covering that. This is due to the previous surgery or the underlying pathology which led us to a VR surgery. So in anticipation of the difficulties I had, we have to modify our surgical techniques and we have to achieve a successful surgical outcome so that our patients attain a good vision. So the history of past surgery is very important. Whether it is a limited vitrectomy or a extensive complete vitrectomy, then that decides how we have to go about it. And third point is whether it is a silicone oil filled eye or not. Because if it is a silicone oil filled eye, it will have shallow chambers pre-op, per-op, and without oil have deep fluttery chambers. Both are different. So our planning remains different. Then comes to coming to IOL power calculation. Though we know that the newer biometers have formulas for silicone oil, because we have to learn this, we have to know this, understand this, that the speed of sound is very slow in silicone oil. In older biometers, we have to multiply the axial length by 0.64 to get the true axial length, because the specific gravity of vitreous oblique specific gravity of silicone oil is 0.982 by 1.532. And we have to prefer optical biometers, especially swept source OCT based if we have access to that. Then slit lamp examination rule out zonular dialysis as silicone oil has degenerative effects on the zonules. There can be a pre-existing posterior capsular defect as PC may have been damaged by vitrectomy probe accidentally. So this can present as sudden formation of mature cataract. If there is a sudden formation of mature cataract after VR surgery, we have to keep this in mind. Then PC plaque. This may not be able to be removed simply by scraping or vacuum cleaning during surgery. So YAG laser may be needed, but do it only after 6 weeks and make small opening to avoid silicone oil spillage. Inform about surgical difficulties. We have to counsel the patient about the zonular dialysis, PC defect, pre-existing PC defect which may be present. IOL options need to be discussed and patient has to be told that we may have to change a 1-piece IOL to a 3-piece IOL on the table. And about PC plaque, that the visual acuity may not be regained fully, so we may have to do a laser later on. Coming to surgical strategy, as far as anesthesia is concerned, avoid topical and intracameral, as intracameral may permeate through weak degenerated zonules and may cause retinal toxicity. As we say that if there is a posterior capsular rupture, don't inject intracameral xylocaine, because that is going to directly have a retinal toxicity. So only topical is painful due to chamber fluctuations. Peribulbar is of choice. Avoid massage or pressure to avoid zonular damage and hypotony. Coming to incisions and rexes, low ocular rigidity may cause difficulty in making corneal tunnel. So inject viscoelastic thoroughly through side port. Prefer larger rexes to avoid capsular phimosis so that in post-op period examining the retina remains easy. Use of forceps causes lesser stress on zonules but depends on individual choices. But if there is a PC defect anticipated, make a normal size rexes to implant a ciliary sulcus IOL. You may be needing the support of intercapsular here. Hydrodissection and rotation, gentle multi-quadrant hydrodissection. I'll be just coming to that in the video. Keep on decompressing nucleus in between multi-quadrant hydrodissection. No hydrodissection in mature cataract in case of suspected PC defect. And proper rotation must as zonules are stretched and weak. So this is what is happening in vitrectomized eyes with and without silicone oil. There is a deepness in vitrectomized eyes without oil, and with oil there is a upthrust, and this is the plaque that I was talking about. Nucleus removal, eyes with extensive vitrectomy with no silicone oil, deep AC with flutter, use Kelman tip, low bottle height and lower parameters. Avoid overfilling with visco. While sculpting, use higher power to avoid zonular stretch. PC fluttering can cause its suction in the phaco probe. Beware of that. and with silicon oil, ideal is to remove, but various studies have shown the incidence of recurrent RD 17 to 30% after silicon oil removal. So we may have to go ahead with silicon oil in the eye. The main problem is forward push of the lens diaphragm, shallow AC, more in supine position, and higher bottle height and tight valvular incision. IOL biocompatibility is a must. So as blood aqueous barrier is compromised, higher uveitis rate. So prefer a hydrophobic IOL only, and never put a silicone IOL if you have a silicone oil in the eye, because oil adheres irreversibly to the back of the IOL. Wound closure, due to low scleral rigidity, wound integrity needs to be strengthened by suture many times. So in this video I'll be showing that how we make a larger axis here, and other steps will be showing. So during rhexis there is no stretch on the zonules. So this, I am just seeing that my nucleus is rotating freely. If I don't do this step, I can cause zonular dehiscence if the nucleus has not rotated fully. So then going to phaco, as I have already said, that we have to make a deeper trench here and use a higher power phaco here during sculpting. The chatter you can see is there because these cataracts are usually hard, especially this is a silicone oil filled eye. So the chopping has to be gentle. Don't try to go make the two pieces too much apart because the zonules are weak. Then you go 180-degree opposite, and going 180-degree opposite, once you have two hemispheres, the things become very simple. And then we now divide the two hemispheres into 3 to 4 pieces each, and then we consume these pieces. Again, I am using a Centurion intelligent phaco mode here, so that I am not causing much of the stress in the bag. Then I am feeding these nucleus pieces with my chopper in the phaco probe to decrease the phaco energy, because we have a shallow interchamber in which we are working, so we have to save our endothelium. So once we have done with this, you can see the glistening. This glistening is typically in cases of silicone oil filled eyes. So once the cortical matter is removed, we can see that the plaque I showed in the picture is there. It becomes very difficult for us to remove this plaque, so better leave it there. Don't fiddle around with this. Don't try that our patient in day 1 or day 2 should have good 6x6 vision. There's another similar video, I'll skip that. This is another video in which there is no silicone oil. So you can see, I'll just show you the moment phaco probe goes inside, there is a sudden deepening of the anterior chamber, something that occurs in LIDRS in high myopic eyes. So now the moment I'll enter inside, you can see that the nucleus and everything has gone down. So this is important. Thank you. Now I invite upon Dr. Saurabh Bhargav for his talk.
So wonderful. Just a question.
Yeah.
So wonderful coverage of patients with vitrectomized eyes. Like I just saw you pointed out that intracameral xylocaine or oculan, whatever is used, might percolate through the loose zonules in such cases and cause retinal
Through
toxicity.
the degenerated zonules,
Right.
because the silicone oil has a degenerative effect on the zonules.
So my question was, many of these vitrectomized patients are high myopes. They must have had an RD, and an RD surgery must be done. Now, in such cases with the thinner sclera and the globe filling the entire orbit, do you recommend a peribulbar, or would you continue with what you just said?
A peribulbar given by the surgeon himself after seeing what is the axial length, rather than leaving it on your assistant to give the block. So that is one important part. But in case it is a vitrectomized eye where there is no silicone oil used, there you can go ahead with topical surgery, because there you can use intracameral.